questions or anything in between, just holler at me and let me know what's going on. Like Dan said, my name's Tammy. I'm a PA here in the city. I've been a PA now, I have like 18 years, so it does feel like forever. I've done most of my training and stuff outside of school in neurology and neurosurgery. I've spent the last 5 years kind of even scoping that down anymore. I'm orthopedic spine now, so I'll probably die orthopedic spine. So from that standpoint, I'm pretty much where I am. So welcome all you guys on board into the program. It's tough, but it's fun, and you learn a lot. It goes right really fast. So sink in all that you can. My talk today is on movement disorders, which is a huge talk. I mean, that's a semester's worth of talk, and we're going to try to cover it in 2 hours. So from there, we're not going to cover a lot of the pathophysiology type stuff, the brain stuff associated with it. You all have either had neuroanatomy or you're going to have it with the king of neuroanatomy. So from that standpoint, from that standpoint, I don't need to cover that kind of stuff. I'm also not going to cover a lot of the pharmacology end of it. You guys will have a pharmacology class and you'll get a lot of the pharmacology, so we'll talk about the big drugs that we use and maybe some of the side effects that may affect the disease, but not really get into the drug itself. Okay. So that's me. On there, that's my email. If anybody needs me, it's usually the easiest way to get a hold of me. If you need me with anything with regards to this lecture, with regards to rotations, things like that, anybody's interested, we're in a big orthopedic practice here in town. So from that standpoint, let me know. The first one that we're going to talk about today is Tourette syndrome. Actually, when you talk about any kind of tic disorders, there's 3 main kind of tic disorders, and they're characterized by how long you've had the disease or what you have. So a provisional tic disorder is something that's, has just kind of come on. It's not lasted more than about a year's time. It may be either motor or vocal tic, so it may be either one, but it's kind of short-lived, and those are the kind of things you just kind of watch for. Those then can progress into 2 other kind of tics. One is Tourette syndrome. Tourette's is characterized as motor and vocal tics, so you have to have both. It has to be longer than a year in duration. So when we look from a standpoint, we've now gone from provisional, which could be motor or vocal, in less than a year, to now that's something that is both but longer than a year. The other one that we have to deal with a lot is just a chronic tic disorder, which doesn't characterize as Tourette's because it has either motor or vocal and lasts for longer than a year. So it doesn't have that whole criteria to meet that you have to do Tourette's. So there's all kinds of things that we can deal with when we start talking about Tourette syndrome. Tourette's has been around a long time. The French author, all the way back in the 1500s, basically did a big book. It was a book on kind of witchcraft and witches and things from a standpoint, but in the book he describes a priest who has this funny disorder, and he keeps moving and making these funny movements, and so he is a big central character in this book with regards. It was then later described a little bit more by a French physician in the 1800s on an actual woman of nobility who had coprolalia. And we'll talk a little bit about what that is and stuff later, and it's a whole a huge documentation of all the way through her life of what happened with her disease. Later, in combination with Tourette, as well as who's a neurologist, as well as Charcot, who's a psychologist, they basically continued to kind of narrow down this disease and really decided at that point in time it was a psychological disease. I mean, there was something that, that was involved in the psyche, and that it was treated through psychotherapy and psychoanalysis. It wasn't until we started using a lot of the neuroleptic drugs in the 1970s to start working on some of the early antipsychotics and things like that, where we saw a reduction in tics when we put people on these, that they started thinking, well, maybe this is more a brain disorient disease, and it may be more of a neurologic condition than it is a psychologic condition. Then now we've pretty much kind of lumped those together and it's really kind of characterized as a neuropsychological disorder. And we'll talk about why it intertwines into both. Like I said, I'm not getting into a bunch of pathology. You guys have seen this ad nauseum, but when we look at most movement disorders, we're really looking at the fact of between the striatum, which is the caudate and the putamen, and the globus pallidus, the inhibitory effects that it has on the stimulatory effects of what's going on between the thalamus and the cortex. So what they believe is, and what the focus of the research and the studies are right now, is in most of these disorders, they're looking at treating that area of the brain, both it being into the striatum and the globus pallidus, treating that area of the brain to excite, what they believe is that the disorders are coming from the loss of an inhibitory process in those two areas. So you get this extra excitatory process with nothing to come in on the yin and the yang to kind of calm things down. So they're really focusing kind of on this area. And so a lot of times you'll see as I go through the talk, on a lot of these disorders, you know, we kind of focus right back to the thalamus again and right back to that area. And that's the reason why. The biggest thing about this disease is several that you'll see from a standpoint. One is it's characterized by both motor and vocal tics, and it's typically multiple motors. And we'll talk about the fact that when you look at the motors are so different that, you know, people can have multiple ones fairly easy. It has to be longer than a year in duration, which we talked about initially. This is a childhood onset disease. So this is one of the things that you'll see in kiddos that occurs. Usually the median age of onset is around 5 or 6, and sometimes they'll actually grow out of it. The biggest thing that you need to worry about when you're doing these, when you see these kiddos, is make sure before you just pump in a diagnosis of, oh, they have Tourette's, that something's not causing it. Because there are a lot of things that kids are on nowadays and that kids do nowadays that can actually cause some of these things. So we really got to look at their medications and look at side effects of medications. Anybody who's on lithium may have a movement disorder. So if you have kids that are on lithium, it's rare anymore, but it's there. Asthma medications. Kiddos that are on theophylline or on beta agonists that take a lot of beta agonists and stuff will have can have some tic-type disorders and stuff that we see. So we've got to watch for asthma medications. Thyroid medications or thyroid toxicosis in kids can cause it. Neuroleptics, if they're already on it, can have tardive dyskinesias. So we can mistake a tic for tardive dyskinesia. Withdrawal. You know, you don't know anymore. I mean, we think, oh my God, this is just a young kid. They're not on drugs. They're not on alcohol. They're not on that. But you'll be surprised by the number of, you know, very, very, very young children that you have nowadays that are actually already starting to play with drugs and starting to do things. So it could be just a withdrawal symptom of the drug. Also look at the community where the child came from and think about kind of what their living situation and what their social situation is, because lead poisoning or mercury poisoning can also cause these type of symptoms. So we've got to check and make sure that there's not something socially that we're totally missing with these patients. Also, you have to rule out kind of, is there any other medical condition that can be causing it? So did they have a focal seizure? Is this seizure related that we've got to treat them with seizure medications? HD is Huntington's disease. We'll go over that a little bit. That's really important to know because a childhood or Westphal variant of Huntington's disease is lethal. I mean, you know, these kids will be dead in 10 years, and it's a genetic disorder. We'll talk about that a little more, but so that's something you got to make sure that it's not there. And also, are they making it up? I mean, are they trying to do it for attention? Are they trying to do it because they're being bullied in school? Are they doing it from the standpoint of what's going on? So we kind of have to really watch these kids and see what's going on. If you're in pediatrics, you'll see those for sure. Family medicine, I've seen it a couple of times in urgent care. So, you know, from that standpoint, you'll catch up on it at some point. Like I said before, it's the most common disorder in kids, so you're going to see it. Age of onset is sitting around about the age of 6. 1 out of 160 kids have tics. 1 out of 100 actually have some sort of tic. They may have a provisional where it goes away after a year, but 1 out of 160 will be diagnosed with Tourette syndrome. It's more prevalent in boys. 50% will be tick-free by age 18. So a lot of times you can, at least give them some encouragement that, they can grow out of this. So keep them a little focused on what's going to happen. When you look at tick from a standpoint, I think the biggest thing that you come out of it is the fact that these kids will tell you that they get this uncontrollable urge to need to do something. And that need to do something is typically the tick that they're going to do. And that has really now come around full circle with regards to a lot of the treatments associated with it. So these kids will come in and they'll say, hey, I get this uncontrollable urge that I just have to do something. When they do this movement, which is typically an involuntary, kind of rapid, brief, and kind of repetitive, so it's just something that, kind of hits you quickly and you can sit and watch them do it. As soon as they do the movement, that urge goes away. So it's kind of like, okay, thank you, you let go, and we're good. They are worse in times of stress. They're worse in times of excitement. I had a pediatrician that I worked with once who said, went into a patient's room and the family was all excited because their kid has had a lot of social issues and a lot of school issues and has tick, has Tourette's, and they were so excited when they made him through school, and it was first or second grade, I forget, and the whole deal was that if you could make it till the end of school, we'll go to Disney World. Okay? Well, this kid, the ticks went crazy in this child. And the reason it went crazy was because that's something that just stressed them out of the fact that we got to get through school, we got to get through school, we got to get through school so that I can go to Disney World, that his ticks were unbelievable. So, the pediatrician said, look, the next time we start planning on vacations, one, maybe we shouldn't make it such a big deal, and two, maybe we shouldn't put it in a place where you're going to constantly get that excitement and input and everything that's going on, Maybe a trip to the lake where things are nice and calm, or something from a standpoint is a lot better for these kids than having something thrown at them with all this excitement. We as parents just want to, go out and do whatever we can do to make things fun and do a lot. But for these kids, that amount of stimulation is really tough on them. So, sometimes it's kind of helpful to kind of have parents kind of tone it down a bit. The other thing is that a lot of times if you're talking, if somebody's talking to you about your tick or about your Tourette's, then you're going to do it more. So it's that power of suggestion. The more somebody keeps mentioning it, the more I'm going to do it. The other big one, and this happens a lot for kiddos, is when they try to suppress it. So they get that urge, and they try to do whatever they can to say, it's not going to happen, I'm not going to let it, I'm not going to let it, I'm not going to let it. You can't make me do this. And then the more they suppress it, the crazier it gets. So they'll go through actually just a storm of ticks. A lot of times this happens as soon as the kid walks out of school. So, he's been sitting at school all day long, he's been trying to suppress what's going on so his friends don't make fun of him, and he walks out of school and it just hits him like a storm. So those are things that we can do. We do know that physical activities, so sports and things from a standpoint that we keep these kids, doing stuff and keep these kids moving will actually help with it. We also know that distraction can help, and we'll talk a little bit about that when it comes to treatment, on what they can do to try to make it better. Unlike most ticks and most movement disorders, when these kids are even asleep, they'll still do it. So usually in a movement disorder, when you go to sleep, the tick or that movement kind of goes away. But kids will still do this in their sleep. Motor tics that we're looking at, so you can see here from a standpoint is when you talk about having multiple motor tics, that's not a hard thing to do. So, eye blinking is, kind of the most common, but they can have facial grimaces, they can grind their teeth, they can shrug their shoulders, they can bob their head. So those type of things, you can have multiples of those, and they're each characterized as a single tick. So most of them will occur above the level of the shoulders, so it'll kind of occur up in the head and neck region. You will get some kids that'll snap, or they'll clap. Like the more complex ones, the hopping and jumping and doing things like that are pretty rare. But most of the times it's mostly facial issues that you'll see. When you talk about vocal tics, it doesn't necessarily mean from a standpoint of being vocal tics that they actually have to vocalize something. They may sniff, they may snort, they may grunt. They can clear their throat. Clearing their throat's a big one that you see a lot in these kids that they'll go through. They may repeat you. So if they get through whatever you say, they say back to you. Probably the one that we all know and the one that's always on the boards because, you know, it's so different is the cobrilla, and it's basically the use of inappropriate words. So they cuss, they yell at people, they say inappropriate things continuously through. It's one that, you know, all the movies are written about, that's what gets thrown in and everything. But actually seeing it's pretty rare. You don't see it very often. The one thing you do see with this, and this is the reason why we now consider it more of a neuropsychological condition, 85% of these kiddos will have some other diagnosis to go along with it. That may be learning disabilities, that may be attention deficit disorder, it may be OCD, it may be depression, but typically they will all have another component associated with what's going on. When we look at treatment of these kiddos, the first two, Haldol and Pimozide, are the only two that are actually FDA approved. Here's the bad part. These are your typical antipsychotics. They come with a ton of side effects. Most of those are sedation, weight gain. They can also, in certain times, have tardive dyskinesia associated with it, so you can get a different kind of movement associated with just the medication that you're on. So you're trying to stop a movement and you gain a movement by treating with the medication. You have to remember these are kiddos, so, I mean, particularly in girls or things from a standpoint, you can't be putting a 13 or 14-year-old girl on a medication that's going to cause her to gain 20, 25, 30 pounds because they're already in an issue where they're worried about their body type and what they look like and what things are going on. So, also with these, a lot of them with the result of sedation. I mean, then they go to school and, you can't keep them awake in class. So treating them is really difficult. These drugs make them slow down. It makes them, not feel good. So they're not going to like taking them. They use a lot of the atypical antipsychotics, which are some of the new ones that are out, are also being used with regards. They have less side effects as those typical antipsychotics do. So they're a little easier to take. The biggest thing though is with any of these medications, first warning label, increased risk of depression and suicide. Okay? So now you have a kid that's probably being bullied at school because they have this funny tic disorder, and they may have some other psychological diagnosis to go along with it, and everything else that's going on. Now you put them on a medication that increases their risk of suicide. So these kids have to be watched pretty closely if you're going to start treating them. They have used a couple of other things. Clonidine is one that's been used quite a bit, particularly in people with kids with ADHD. Again, it's not a fun drug to utilize with kids. Their blood pressures are typically fairly low to begin with, and then you put them on, a medication that can drop their blood pressure even more. And you do that, and then now they're sluggish and slow, or they have orthostatic hypotension, or they just don't feel well. So from that standpoint, be careful. Topamax and Keppra, it's been used in the past. It hasn't been shown to be very effective. We'll talk a little bit more about Topamax later. Antidepressants, used more and more in kids nowadays. Obviously you want to go to your more specific ones, either the SSRIs or SNRIs. But again, when you're dealing with antidepressants in a teenage population, the number one risk of treating them with those is their increased risk of suicide on these medications. So we have to be extremely careful with regards. Stimulants were initially thought, well, that's pretty stupid because if you stimulate them, their tics get worse. But some of these kids that have ADHD and you put them on stimulants, their tics actually do improve a little bit. So it's probably kind of an anxiety type scenario that you kind of got them to, relax and settle down and focus with the ADHD medications. So it's been used more to treat kind of the comorbidities than it has been to treat the tick, but it has been shown to be effective. There's actually several studies out right now on the use of THC, the use of marijuana, and it's really effective. The bad part is how many people want their 6-year-old on marijuana, so that's it. Botox, they use a little bit. Some of the neurologists around here even use a lot of Botox in most movement disorders. In a few of the studies that showed through, this is a big multi-center case, so they looked at quite a few kids, and they did see better than 90% improvement in the ticks. 50% of those were tick-free. It's not permanent, so the use of Botox to kind of stop some of these things. Every 2 to 3 months you're treating them again, and that's lots of needles and sticks and stuff, and these kids sometimes don't like it in regards to that. Plus, you also have to watch out for the side effects of Botox. So it can actually mess things up more than anything. You get an eye drop that can open your eye. That's you're not going to be blinking it very often, but you also can't open it. So we have to be really careful with that. This is probably one of the ones that's been getting the biggest amount of publications right now. Comprehensive behavioral intervention. We talked about earlier that distraction may actually attenuate some of these tics. This is something that you can do. It's a certification, and you can actually get online and get certified with it anymore. Before, you used to have to go to places and do it, but now they have it to the point where you can actually get online and get trained. It doesn't take very long to get training. It also doesn't take very long. It now has a CPT code to it, so you can actually bill for it. But it doesn't take long to train your kids. The important part about this is you have to have a kid. One, it works better in kids that are older. Two, it works better in kids that don't have an ADHD diagnosis, because you have to have a kid who's really willing to be self-aware, pay attention to themselves, and want to make this better. But basically what it is a standpoint of you train the child that for when they get the urge, they do something different, which a lot of times will remove that urge, and once the urge is moved, then they don't have to do the tick. Now the problem is that you're training them to do something different when they get the urge, which, what's the difference? Doing the tick and making the urge go away, or doing something different. And most of those are a click, but they'll teach them to snap their fingers. Or a toe tap, that they'll teach them to tap their toes. And so a lot of the kids that were doing this, that initially it was kind of weird, but then what they found out was that if it happened at school, they could throw their hand underneath their desk and kind of, sit and clap their, click their fingers quietly so nobody else heard, but it wasn't as obvious as them making, a really crazy face, facial feature, and it would actually help distract them. The studies, the multi-center study that was out there is more than 50% of the kids were almost tick-free when they did this. And it lasted, they followed these kids for 6 months to see, if they would continue to keep doing it. None of these kids were on medications. So they weren't being treated by anything at all other than just kind of this behavioral training that was going through. So it seems to work out good, but like I said, it's got to be, the ones that are older. It's probably the ones that have had it longer, the ones that are definitely more self-aware and who want to kind of help themselves. If they don't want to, then it's not going to work. So you have to be picky. Deep brain stimulation was a talk about it for a while. It's still on the list when you look at DBS and what it's been approved for and what its potentials still are. It's still sitting over here on this potential thing, but it's not approved at this point in time. Again, where are we pointing? We're pointing that lesion at the thalamus, the internal capsule of the globus pallidus in that area. And what a deep brain stimulation is, we'll talk a little bit more about it. And actually, if we get done in time, I used to have a couple videos of my own patients, and somewhere along the line I've gotten rid of them, and probably now that I'm not in it anymore, I'd probably be breaking HIPAA if I showed it anyway. But we can plop on YouTube, and if anybody hasn't seen what deep brain stimulation does to tremor or to Parkinson's disease, it's freaking amazing. And for doing it for 7 years, it was, I mean, it was probably one of the most rewarding surgeries I've ever had. So from a standpoint, this basically puts an electrode into a region of the brain, which then you can use, turn up the electricity that goes into there to stimulate that region of the brain. So we think that, you know, there's a block in the inhibitory pathways in this area that's stopping and allowing those movements to occur. If I excite this inhibitory area, can I get more inhibition and slow things down? And so that's what we look at, and that's where we deal with deep brain stimulation. But like I said, in Tourette's, right now this is a child, so you know you're not going to implant a device into a kiddo's head unless you just really have to. With regards, particularly since you know half of them are tick-free by the age of 18. You know, now what are you going to do with the stimulator that's stuck in the middle of their brain? Not approved for this yet. Just for your all's information, the Tourette Society is actually extremely active. They're always doing, you know, walks and educational seminars and stuff for both providers as well as for families. You know, these kids are really affected, and sometimes it's good for them to be around other kids who had it so that they can talk through what's going on in their life and what's happening. But it's also really important for the parents, because parents just need to know that there are other people out there that have to live what they live through, and so it's really helpful. If you have problems and it's a really complex case and you want to send patients, the closest center of excellences here are at Baylor in Houston and Mercy Children's in Kansas City. Both of them have very, 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 very large programs. So if you're looking at, you know, needing something big, then that's the area to go. Okay. All right, that's Tourette's. Let's move to more adult stuff from here on out. Essential tremor. Okay, I'm old, Dan's old. Who knows who this is? Same thing last year, Dan. Nobody knew who this was. Anybody know? Has anybody ever heard of Katharine Hepburn?
Yes. Are you people not from this world?
Nobody knew last year either, so I'm not surprised. It makes you feel really old on what's going on. Katharine Hepburn is probably one of the most famous people that we know from a standpoint of essential tremor, and it's because it's in her voice. So if you ever want to know what one sounds like from a standpoint of voice, Google On Golden Pond, okay, and watch some of the clips from a standpoint and listen to her voice, and you'll see what's going on. Essential tremor is an involuntary, rhythmic, oscillating. So as we go through it, you'll kind of understand what all that means. Movement of the head, the arms, or the voice. If it's in the legs, it's not essential tremor. Okay, there's something else going on. So it's always in the upper half of the body. Common. You guys will see this all the time. There is a genetic basis. What the gene is, we don't know, but they're still working on it with regards to what's going on. But they have been able to characterize it as it is autosomal dominant. So if you have a family member that has it, if your parents have it, if your dad has it, 50% chance you're going to have it. So from that standpoint, it kind of follows in that autosomal dominance pattern. And is really important as you start to talk to the patient about what's going on. So do you have a family history? If they do, you got a 50% chance of getting it. So from that standpoint, that's going to help you. This is kind of midlife area, so we're talking mid-40s to early 50s. You'll start seeing a lot of this. Like I said, location, head, arms, hands, voice. Lower extremities, not essential tremor. Just like you looked at it in tic for Tourette's, don't forget from a standpoint of going, look at their medication. What are they on? Are they on something, or is, you know, particularly if this is something new. If they came in and they've never had this before, and all of a sudden now they come in and they've got this movement that's going on, you know, is it something new that one of their doctors have added? Don't forget, particularly if you're in family medicine or urgent care or one of those areas at the ER, some of these patients that you'll see may have 5 or 6 doctors, okay? And every doctor puts them on 1 or 2 pills. But none of their doctors will look back and say, well, what were you on before and what will happen when I put you on these 1 or 2 that I have you on? So you always have to kind of look and double check those. I'm doing it all the time in surgery because I come in and I've got a patient that's on 3 beta blockers. Really? Why? Well, my family doctor put me on, and my cardiologist put me on one, and somebody else put me, my neurologist put me on because I have essential tremor. So they're all on 3 beta blockers. And you're like, well, I wonder why your heart rate's at 42. So from that standpoint, figuring out and really looking at patients' medications a lot of times, particularly if they've added something new, that you'll figure out what's going on. The good news about this disease is it's pretty slow to progress. It typically starts on one side. It may, over time, advance to the other side, but usually it'll be more associated. You'll get a lot more movement on one side than you do on the other. But it does progress. So you have to continue to try to figure out how you're going to treat these patients as the progression goes. And it can be pretty debilitating to patients along the way. So we'll talk about social isolation and things like that can happen to a lot of these patients. Similar to any kind of tic disorder, if you're tired, if you're stressed out, you're going to have this, or it's going to make this worse. Caffeine, my energy drink in the morning, is going to make this worse. So those type of things is a lot of stuff that you have to talk to your patients about to try to get them to kind of change their ways and change what's going on. This is a movement disorder associated with movement. So the more that they try to do something, the worse that the tremor gets. So you really have to kind of watch with that, and we'll talk about that as far as with ADLs and stuff. Most common tremor, they say 5 million have been diagnosed, but probably 10 million have it. A lot of your patients will come in and say, you'll see them, and maybe the first time you've ever seen them, and you ask them, oh, well, you have essential tremor. Have you been treated for it? And they look at you and they go, no. Do you have a doctor for it? No. Why? Well, my mom had it, my grandmother had it, my grandfather had it. From a standpoint, doctors never did anything for them, so I don't know why they're going to do it for me. It's just we all get it. So that's a lot that you'll see. So a lot of these people won't even go to get treatment because they just, everybody in my family has it, so therefore I must have it too. And we have treatments for it, so it's good to kind of convince those guys that you need treatment. I mentioned before, it worsens with stress, fatigue, anxiety, movement, so a lot of these things that we'll treat will kind of calm those type of things down. The biggest thing you have to watch with these patients is one, we said it's progressive, so it's going to get worse with time. So when they first come see you, it's going to be really important to know, what do they do for a living? Because if it's their dominant hand and they write for a living with pen and paper, their writing is going to go to shit over the years. So from that standpoint, what do I need to be thinking about now that will help them either maintain their current form of employment, or do we need to do some vocational training? Do we need to do some vocational rehab to kind of get them to the point where they don't have that issue later on? Social isolation in these patients is big. So, you now get the 60-year-old who's had it for 20 years or 15 years, and it's dominant in their right hand, which is their dominant hand. Being able to feed themselves is almost impossible. You put peas on a spoon and they end up with more peas in their lap than they do in their mouth, or try to eat soup. So these guys, they don't go out and socialize with friends anymore. They don't go out to dinner at restaurants. They don't go do anything anymore because they're embarrassed. So when you talk about those type of people, you've got to think about the fact of what's it doing to their lifestyle. So starting to get them help early and getting things go through. Not promoting alcohol, but it does show from a standpoint is that moderate amount of alcohol will actually suppress these. And that should be in your history taking when you're there from a standpoint. You ask them, well, what makes this worse? Well, what makes it better? And they go, well, if I have a glass of wine, it kind of stops. Okay, that's pretty pathognomonic of the fact that it's an essential tremor. The other thing is unlike ticks, when these people go to sleep, their ticks go to sleep, or their movement goes to sleep too. When you examine these patients, you're going to notice that their tremor gets worse when they go to do something. When you have them reach out to pick something up. If it's right here, close to them, they can do okay if they're supported. But if they have to reach out to do something, it's going to do it. If they got their hands out here, you start holding it posturally, you'll start to see this one just start going, okay? Fingers to, inflection point, you'll start to see this start to roll, that they'll start to have this tremor. If it's a vocal tremor, ease and ahs, just like you would listen for a consolidation, will kind of help with that. You'll kind of hear that more if you have them repeat those over and over again. It's important with every visit that you kind of see it to address, and I used to keep it in their file, even though we had electronic medical records, I just scanned it in their electronic medical record, is I would have them do things like write a sentence, draw a face of a clock, do the spiral test, where you do the little spiral thing from a standpoint and have all that written down. And about every 6 months to a year, we'd repeat it just to kind of see, okay, how are we advancing? What's going on? What has the medicine helped? Is it not helping? Do I need to get them now to an occupational therapist because they're starting to have some issues, and we need to see what we can do to help them. Fine motor tasks for these people are just awful. Trying to even screwing a light bulb in. But using small, glass screwdrivers and stuff, they can't do any of that kind of stuff. So it gets really a little debilitating. When we look at things early, we got to start thinking and talking to patients about what this is going to mean to their life, what we need to look at now so that we can try to get things going. So vocational changes, do we need to worry about their work? Do we need to worry about what they're doing? A lot of the psychologists are using biofeedback and relaxation techniques to help with these. Do I need to get them over to one of the psychologists to kind of see if we can utilize some other technique, because maybe the patient doesn't want to do medicines right now. They're not ready to start any kind of medications. Is there something that I can give for them that will kind of help make that better? Encourage them not to drink this stuff. It's not good for you. It's not good for me either. I have SVT and I still drink it. Encourage them not to do this. A lot of these patients, if you convince them before they get ready to go out to go do something, that if you just sit down at home about 30 minutes or an hour before you go, drink a glass of wine, get yourself calm, you got about 3 hours that things will kind of calm down. So a lot of times, just them learning what they can do before they go into a stressful situation to kind of limit what's going on, that's a big help for you. Occupational therapists also have things like weighted spoons, weighted forks, weighted pens that can do things, because we know that if they have a weight in their hand, or wrist weights, and now they're making them that they look like bracelets. So, it just looks like a normal bracelet, but it's got an extra weight on it, and that weight that's there helps them get through what they need to do and helps them so that they don't have that tremor that goes through. And they look just like, your normal utensils with regards to what's going on. So, getting those things already ahead of time, and, they just pack them into their purse, or pack them into, pack them into their wife's purse, and they go out to dinner, and you just trade out the silverware, put your silverware on, and nobody knows the difference. So those are type of things that you can really help with your patients, and you don't think about a lot of times because you're thinking about medically what can I do. But these are a lot of things that help them more than any drug you can put them on, is knowing that they can keep their lifestyle the same. First line of treatment for upper extremities, head, neck, and stuff is a medication called Myceline, Primidone. We used it a lot. I worked with Kimberly at the VA. I think Kimberly was here yesterday, wasn't she? She sent me a text message this morning. We do this a lot. Here's the important part about Myceline. You feel like crap when you start taking it. Okay? You definitely feel like you got the flu. It's nausea and body aches, and it'll get better with time, but you just gotta get the patient past how they feel to take the medication. So, like every other drug that you should be doing, start low, go slow, titrate it up, use the least amount that you possibly can. Reason being, one is because of the side effect, two is because they develop tolerance to this. So if you just smack them with a maximum dose initially and say, yeah, it's okay, you'll feel really bad for a week, but then you'll get better, it's going to come back in about 3 months and then you're not going to have anywhere to go. So just work them up slowly, try to get them to the point where they're comfortable with the medication and comfortable with the tremor, and it may not go away, but at least they can function with the tremor that they have. Just like any other drug that's in this kind of line, be careful with your impaired patients because you're going to make them more impaired. The other one that we utilize a lot, I didn't utilize propranolol as much as I used Mycilene, but primary care and stuff, you'll see a lot more propranolol use. The good news about propranolol is you can use it either as needed or you can use it chronically. You can use it on a daily basis. A lot of people will use this as needed in the early stages. When they know that they're getting ready to go out someplace, they'll take a little bit of propranolol 20 or 30 minutes before they go. And it will kind of hang in there for a couple hours from a standpoint and reduce their tremor. It will not make their tremor go away, but it will reduce what's going on. If you use it chronically, same as the Mycilene. Start it low because they're going to build a tolerance to this, so start it low and slowly build it up. Remember what their other diagnoses are. So, I mean, if you're starting this, remember it's a beta blocker. So if you're starting it and they're already on 3 other beta blockers for something else, you've got to make sure that what you're putting them on is one that you're going to be okay. Also, if they're a bad COPDer, or if they're asthmatic and you put them on a beta blocker and they're having to use their beta agonist, they're having to use their albuterol 19 times a day, and they're saying, I just can't get any benefit from this albuterol anymore. Well, they're not going to because you got a beta agonist and a beta antagonist at the same time. So from that standpoint, you're not going to get the relief of what you need. So just be careful with what's going on. Propranolol now is in a sustained release medicine too, to where you can take it once or twice a day. A lot of people are using it, but I think the majority of the patients that I had, at least, that were on this, found that their tremor was better regulated by an immediate release. So something that lasted short, not something that just had that extended release. So, as much as the patients wanted to be on something where they only had to take 1 or 2 pills a day, they found that they got better control if they took the shorter ones. So a lot of them would stick them in their pocket. They'd come into the clinic and they'd have 2 or 3 stuck in their shirt pocket. And because they knew, depending on how long they were going to be out that day, if it started returning, then they'd maybe break one in half, or they would take another full propranolol. So keep that in mind. Sometimes it's convenient to put patients on medicines only once or twice a day, and the patients will be more compliant. But if it doesn't help with their tremor 6 hours later after you take it, they're probably not going to be very compliant with it anyway. So it might be easier for them to be more likely to take a shorter acting one and actually control the tremor. Second line of treatment, my least favorite drugs in the entire world, benzodiazepines. You'll have patients that'll come in if they've had essential tremor for a long time. Oh, nothing works, but if you give me Xanax, it works great. And at that point in time, they're now on 2 milligrams of Xanax about every 6 hours. So they're just walking zombies. Benzodiazepines do help with anxiety, and if your tremor is caused by anxiety, then it's probably going to help with your tremor. But benzos are extremely addictive. They're extremely potent. They're probably worse than a lot of narcotics out there with regards to what's going on. And as much as they keep taking their narcotic prescriptions away, I can't imagine how it won't be long before they start pulling some of our benzo prescription abilities away too. Huh, Dan?
Coming.
Okay. So, so from that standpoint, I wouldn't be surprised that you'll start seeing a big reduction in that. So, yes, it does work. It works in combination with meds, but just, be careful what you're prescribing. Topamax. Is anybody here on Topamax? Good. Okay, I can bash Topamax. And it's not bashing it. If there's any Topiramate reps in here, I'm sorry. I use a lot of Topamax. Topamax can be used for a lot of things. It's an anti-seizure medicine. It works for migraines. It is now huge in the weight business. So if you're process of losing weight, it's now gigantic in that. For the longest time, everybody wanted to use Topamax was a miracle drug. You could use it for anything and everything. And I still use a lot of it, and I like it, but I also caveat that with the fact that this is a medication that most of the time requires some pretty high doses to be able to treat everything. And it usually means that you have to give it more than once a day, and the higher you go, the better the effect, however, the better the side effect. I call it my stupid drug, my stupid pill, because the higher the dose you get, the dumber you get. And so I always caveat with this medication is we can try it and we can start it, but if you start forgetting things, if you start doing stupid stuff, you've got to come off this drug because it really will affect you. Good friend of mine, PA, bad migraines. Bad migraines. Topamax has worked great with their migraines. One dose works good, the other dose works great. One dose, they can go in and talk to a patient and do what they need to do and walk out and grab the dictaphone and dictate the note and get things done and move on. The next dose, they walk into the room, do perfectly fine with the patient, can talk to them, sounds perfectly logical, makes the plan, everything's great, you would never know the difference, walks out of that room, closes the door, grabs the dictaphone, can't remember a damn thing they said inside of the room. Okay, so that's not very helpful in our profession. So from that standpoint, make sure your patients know, we're going to start this low, we're going to start increasing it, we're going to see how it goes. But the first time you start noticing that this is affecting you, you got to quit. I mean, we got to bring it down. You cannot take it any higher because it won't go away. It just gets worse. Okay. Gabapentin doesn't do anything. So it's on here just because they use it, but it doesn't do anything. Botox, again, just like Tourette's, from a standpoint, a lot of the neurologists are using Botox, particularly in head and vocal movements. The vocal ones, though, that you have to be really careful with is in the first couple of weeks or so after they get Botox, they almost can barely speak at all. They don't have that tremor in their voice, but boy, you're standing here like this going, what? Because you can barely hear them. So it's good, but if their job requires them to sit on a phone all day long and do an answering service, they're not going to have a good time with Botox. This is one actually that surgery has helped a lot. Initially it was a thalamotomy, where they would go in and actually put a lesion in the thalamus. You can only do that unilaterally. And the reason you can only do it unilaterally is just because that's a big relay system for a lot of things, particularly speech and visual spatial stuff, from a standpoint of what's going on. So if you did it both sides, you would get a lot of complications in these patients where their tremor's gone, but they can't hardly speak at all anymore. So we have to be really careful on the surgery. You don't see it a lot, but these patients do very well. I mean, more than 80% of them have almost complete removal of the tremor. So they do extremely well. But the other thing is once with surgery, from a standpoint, we'll get a lot of recircuiting. So then sometimes we can get a little bit of recurrence back to them. So about 20-25%, you'll see some recurrence that'll occur. Usually not as bad still as what it was before, but it's there. When we started getting that good a treatment with stereotaxic surgeries, then actually going in and doing deep brain stimulation and essential tremor really came on board. It's put into the ventralis intermedius nucleus of the thalamus. There's either 1 lead or 2 leads. It depends if a patient comes in unilaterally. You know, we would just put one in on the contralateral side, of course, to kind of help control the movement. Then later on, if they developed on the other side, we could take them back to surgery, throw it into the other side. The battery just sits here underneath their collarbone. So you just pull the battery out and you just change the input so that it regulates both sides instead of just one. The good thing about stereotactics, or the good thing about deep brain stimulators, is because it's controllable. You know, that you can change the waveforms and stuff of it. If you start getting dysarthria in these patients, if you start having speech issues with it, then you just make adjustments to it so that they can get tremor control without the bad side effects that you would get from an actual stereotaxic lesion of the nucleus. They work great. I mean, it's literally, we would have patients, I was kind of mean, we would have patients that would come in who would be whining and carrying on as, oh, the other day I was doing something and my tremor came back and I need you to adjust my stimulator. When I first started these, it wasn't very financially beneficial because there were no codes for changing changing the stimulators and doing stuff with them. So you would sometimes you could spend an hour with these patients just dinking around and do something and then I'd say I'll be back in 20 minutes and have to come back and you get paid for it all. But now it's more popular. Deep brain stimulation is a lot more popular, so you can actually get paid fairly decent for the appointments and stuff now. So once that started, it kind of was like, well, you haven't been paid for this all along, so now that we're getting paid for it, how it comes, it just turns into cash in my pocket. So that was a good way to start, getting some bonuses with regards to what was going on because we were getting extra billing with regards to these stimulations. But you'd have some of these patients come in and they're cantankerous and, my tremor's coming back, this thing doesn't do anything. I'm like, really, your tremor's coming back? Yeah, well, I don't see it, And, these people will sit there and, their hands just like this, I don't see any tremor. Well, look, and they'll go to grab something and they'll maybe have this little itty bitty tremor that's going on. It's like, God, that's awful. And you just take their controller, snap it on the battery, turn them off. And the next thing you know, within 2 minutes, they're like this, and I'm like, okay, so what's bad and what's good? So these patients sometimes have to be reminded that, you can get a little bit of tremor and you can be okay with it, but, we need to turn these on and off every once in a while to remind them what it's really like to have it. But it's amazing to watch them. The minute it turns on and they just stop tremoring. So it's a lifesaver for a lot of patients. Like everything else, there's a foundation for it. So, they do a lot of stuff to help you, your patients, get you to certain centers. They do deep brain stimulator here in the city. They do deep brain stimulator in Tulsa. So from that standpoint, there's several neurologists and neurosurgeons around the area that do these, and the patients do extremely well. So if it gets to the point where medicines aren't working anymore and you've got a patient that has it really bad, it's not a bad thing to think about and to talk to your patients about. The companies, Medtronic usually does most of them. There are a few more now, but Medtronic is probably the biggie that's out there, and they have a huge display of patient information and videos and DVDs and all this kind of stuff that they send out to the patients that really go through everything with them. That usually by the time the patient goes to see who they need to see, the patient knows more than not what the doctor does, but I mean, they know a lot about what's going on, so they're usually fairly educated and have some good questions. That's enough for essential tremor. Let's move on to Huntington's disease. Who knows this person? Ha ha ha! Who is it? There you go. Probably one of the most famous people that we know with regards to when we're talking about Huntington's disease. This is a bad disease. So the other bad part about it is remember, he's from Oklahoma. There's a lot of descendants from that area, and there are pockets of strong Huntington's disease in lots of areas in Oklahoma. So It's, you know, a lot of states will say, oh, this is something you'll probably never see unless you're a neurologist. But in Oklahoma, you'll see it. It's something that has always kind of got to be in the back of your mind. Good news is that the majority of these patients, when they come see you, or when they're there, they kind of already know in the back of their mind that something's going on, because there are sporadic mutations to the Huntington gene that can happen, but the majority of them are going to run into an autosomal dominant pattern, and somebody in their family is going to have the diagnosis, and because it's such a strong genetic diagnosis, you know, everybody in the family is going to know, but they hide it because they don't want the stigma of having it. So they may know that they have it, and they may try to avoid telling you what's going on. So you kind of have to pry out things from them that that they won't catch on, that you're kind of leading that direction to find out what's wrong with them. And they can get downright mean, so be careful. Disease was first described by George Huntington in 1872. It wasn't until 1983 that they found on the short arm of chromosome 4 where the mutation occurred. It comes into the Huntington protein. In the end of the Huntington protein, there's a bunch of CAG or glutamine repeats that are there. And what they found is that the course of the disease is the number of CAG repeats that are at the bottom of this protein. So the more you have, the more severe the disease is going to be. So it's something that's the first thing that, you know, when something like this pops up or something happens is you know, getting these people in for genetic counseling and for genetic testing to kind of so that we can base on what's going on. Same time they discovered the gene and figured out that it was a CAG repeats in 1993, that's obviously when they came up with genetic testing, because now we can sit and look at it and see what's going on. Like I said before, it's autosomal dominant, so if somebody in the family has it, there's 50% chance that you got it. So that's the reason that genetic testing is so crucial with us. It does come in on the short arm of chromosome 4. It's a gene that encodes for the protein Huntington. It results from the CAG repeats that are there. Normal should have less than 27 repeats. If you have more than 40, you have Huntington's disease. There's a space in between 27 and 40. So that's the iffy zone as to what's going on. But if you have less than 27, you're good. If you have more than 40, you've got the disease. And this will tell you from a standpoint. So at 37, you're at about a 50% chance. So it's kind of that middle ground, that between the 27 and 40, just means that, you know, maybe you'll get it. Most of them will get it much later in life. Most of them will have not quite as severe symptoms that occur with it, but they probably still have some of the characteristics of Huntington's disease. Over 40, 100% chance you got it. Over 60, big one to make sure that you follow out. This is a Westfall variant. We'll talk a little bit more about it, but it's the kind of childhood or younger onset. It is way faster with regards to progression and dementia and issues with it. The lifespan of these people are usually less than about 10 years. So it's important to catch these, and the reason it's important to catch some of these is the fact that if you catch them early enough, you're going to probably catch them before childbearing age, which means that hopefully through genetic counseling, you can convince them not to procreate, so that they won't give it to their children. The bad part about it is the ones that have greater than 40 repeats that don't show up until they're about age 45 or 50 with the disease and nobody had any genetic counseling in before then, chances are they've already had children, and then you're worried about what's going on with children. Pathophysiology, again, right back to the same exact area that we think that what's going on. On one side of the screen is the control brain, and really looking kind of at that area. Does this thing work? Is it a pointer too, Dan?
You have to use that stick.
The stick. Okay, well, and you guys can see it from a standpoint. So when you're looking at the thalamus with regards to what's going on one side, the left side is the normal brain, on the right side is that You know, you'll have enlargement of the lateral ventricles, because that brain just shrinks in right around that whole thalamic area. It's progressive, that's at an end stage. So these patients will continue to get this atrophy in the brain, and you'll see that quite a bit.